Um, uh, Thank you, Liz. I'm Dr. Joy Rallman. I'm the director of our Center for Global Surgery, and it is my honor today to have Dr. Patrick Eucalitto, one of our new OB/GYN faculty, join and give a talk. And every year we try to have at least one talk that is specific to women's health. And in part because the Center for Global Surgery has always been a collaboration between the surgery department and the Department of OB/GYN. And so we try not to just be focused on the general surgery aspect. We try to be thinking about surgery as a much bigger field that is more inclusive of all these different clinical disciplines. So with that, I'd like to thank Dr. Eucalitto for making time to give this talk and to come in from clinic. And please take it away. And I'm sorry I could not be there in person today to actually introduce you.
Suda, thank you so much for the intro, and thank you for the opportunity to talk to you all today. Thank you guys for coming. I know you have a lot of things to do during your day, but I appreciate you taking a little bit of time to hear this. We'll talk for less than 30 minutes and have some discussion afterwards, and keep it informal in the sense that if you have questions or you want to stop me and clarify anything, please don't hesitate. Sometimes I might slip into more OB jargon, and I'll try not to, but if I do and anyone needs to clarify, I apologize. So just please ask. The topic I want to talk about today in relation to global surgery is the global cesarean epidemic. It's my experience from the past year living and working in Kigali, Rwanda. Some surgical experiences and some data that I've got cite to help sort of illustrate the point that C-sections are super necessary to save the lives of many moms and babies around the world, but they can also be super problematic and super dangerous. Next. And do I aim this at anything in particular? Sure, it's okay. So this is me, I'm Patrick. I just joined, as Suda said, the GYN department. And for global health, I'm starting as the associate director of the served women's health, sort of newly created within the GYN department, to dovetail with the fellowship that I did. And that's sort of how I got here. My fellowship was called the Women's Health Equity Fellowship. And I came specifically to University of Utah in order to do that program because I really liked the way that it was structured. I really liked the mission. I liked the values, and I liked the clinical experiences that were embedded in it. I lived and worked for a year on the Navajo reservation in a small town called Fort Defiance, practicing at a rural tribal hospital that had spectrum OB/GYN care. That was the first year. And then during the second year, I went to Kigali, Rwanda. Here at this picture you see on the right, that's the maternity ward of the largest public hospital in Rwanda. That serves a majority of the country, both patients who are located, which is a city of about 3 million, as well as patients who are transferred from rural areas all over the country for complicated cases related to either obstetrics or gynecology. So how many people in here have ever seen a C-section in real life? Uh-oh. So this is a sort of weird, maybe not accurate picture of a C-section, but it looks sort of like this. It's an alternative way of delivering a baby instead of being through the canal. And there are lots of indications and lots of reasons why we would want that. Some reasons, and then there's some reasons that are not so good that happen anyway. In summary, a C-section is a life-saving treatment that, like I said before, can save maternal life. But we have to keep in mind that, well, and on that point, it is very common. It's the most common abdominal surgery in the United States and in most high-income countries. It's major abdominal surgery. It requires opening the abdomen and the peritoneal cavity, as well as the uterus, which is a definition of contaminated viscera, right? The uterus communicates with the vagina, which communicates with the outside world, which has lots of bacteria. And so we're opening that inside of a patient, and it is risky. There are risks of hemorrhage, damage to nearby structures like the bladder, the fallopian tubes in the ovaries, the intestines, the ureters, and damage to any of those things can cause both short-term and long-term complications for patients. There's also a range of post-operative complications like the pain that it takes to recover from a C-section, infection risk, blood clots, admission to the ICU, and death. It also takes generally a difficult 6+ week recovery. Recovering from a vaginal birth is also not easy, but C-section is harder and hard in different ways. And for many people, experience seems relatively more cumbersome than recovering from vaginal birth. And the surgical risks that I was mentioning increase with every subsequent C-section. So each subsequent C-section that we do for a single patient is more dangerous than the last. And that mainly relates to how the body heals after abdominal surgery, the formation of scar tissue, and the way that anatomy starts to get distorted over time with multiple surgical procedures. But there are a few other reasons for that we'll see as well. So does anyone have a guess? What do you think is like the right amount of C-sections that should happen? Like of all deliveries that happen, how many of them should probably not come out the vagina? Yeah, 20% is an awesome guess. That would be ideal. It's kind of a trick question because, as you can see here with this map of the United States, there's huge variability even just within our country. So you can see the white states where the C-section rates are pretty low, right around what Jane said, our goal of around 20%, all the way to the green states like Florida, where I come from, where the rate is up to over a third, as high as 35%. So in the US, it's been pretty constant for a while that the range is between 1 in 5 deliveries to 1 in 3 deliveries, at least in this country, that are done in C-section. How about globally? Has anyone heard of, or is there like a target? It's also kind of a trick question. The WHO says that our goal for any health system should be about 10 to 15% for the C-section rate. And that is considering all of the pathological processes that can happen during childbirth that may require delivery by C-section. This is from a statement on cesarean section rates that the WHO released in 2015. The data for 10 to 15% is actually from 2 studies from like 1985. It's really old and it's like kind of made up and it's maybe not super relevant. If you can find this graph here, a single number doesn't make a lot of sense to sort of one size fits all an entire health system or an entire population. But it does sort of give us a benchmark to say that when we see rates 60% at a single facility, something might not be going right. In an effort to move away from this idea of a single number, the WHO has more recently said that every effort should be made to provide C-sections to women who need it, and not do it in times that are not indicated or sort of unnecessary. And that can help us target better rather than just trying to achieve a specific number. So this concept of the cesarean, any questions so far, by the way? Cool. So this concept of the Cesarean epidemic is demonstrated here in this graph from 1990 up until 2015. As you can see, the overall trend is very much upward from down under 10% for a lot of countries up into over 20% for a lot of countries. And I'd just like to draw your attention to the 2 sort of sharpest curves, which are this dark one here showing Latin America and the Caribbean, which has gone up to over 40%. And then this dotted yellow line here, which is, yeah, you can see my pointer, which is sub-Saharan Africa, which is also experiencing a sharp rise, reaching up toward 30%. You can see that Oceania, North America, which are represented by these blue and red lines, and Europe have done a decent job in the last years to sort of flatten their increasing curve. And there's a lot of work, quality and safety, and like patient quality and safety initiatives in hospitals to try and more accurately follow and mitigate the rising C-section rate, including in the United States. Modeling from this data shows that if we don't do anything now and we continue at the current rate, then 28.5% of women worldwide will be giving birth by C-section in 2030. 2030 is like pretty soon, strangely. So that is alarming a lot of people and is inspiring work to try to better understand why these rates are rising in different places and what we can do to bring them down. If you take that rate of 28.5% and extrapolate it to the global population, that would result in about 38 million cesarean deliveries that are done annually all over the world. There would be huge variation from about 7% sub-Saharan Africa to about over 60% in East Asia. But if you think about 38 million surgeries, the amount of personnel time, the resources, the costs to healthcare systems, and then the recovery and morbidity incurred by patients from just having to have these surgeries is a pretty big deal. And we're talking about C-section rates being high. It's easy to sometimes forget that C-sections are necessary and that there's such thing as too many, but there's also such thing as too few. So there are places and communities where C-sections are not available as much as they should be, and really bad things can happen to both moms and babies when C-sections aren't available. So too few is always something to consider, and there are certain health systems that actually need expanded access to cesarean deliveries. They need the space to do it. They need the materials and equipment to do it safely. They need antibiotics, and they need the person to be who are paid a normal wage and can show up to work and do C-sections with specific skills. And that's missing in a lot of communities, including in the burden of too many C-sections those are numerous also. There's increased resource utilization, there's strain on healthcare systems, there's costs, there's surgical morbidity, and then there's complications in subsequent pregnancies for individual patients, which also then have big burdens on healthcare systems when they're seen and looked at as a population level. So I have a few photos of some C-section related complications from my time in Florida. They involve organs, and so if you don't want to look at them, that's okay. Change them, but these patients are all consented to photographs of their anatomy, and the photos are sort of as de-identified as possible. This first one is a common complication from C-section that we see a lot here. We actually have a center for it here at University of Utah, placenta accreta spectrum disorder. This is a uterus. This is a cervix. This is a placenta. And the placenta is supposed to nicely and easily separate from the lining of the uterus after delivery of the baby. In placenta accreta spectrum disorder, the number one risk factor for which is a prior C-section, the placenta pathologically invades into the wall of the uterus, and those trophoblastic cells grow into the myometrial fibers, into the muscular wall of the uterus. And it can go in a little bit, or they can go in a lot, like all the way through the uterus, and they can grow into other organs, like into the bladder or into the bowel, and it can be a huge mess. And doing those deliveries are super complex and fraught with morbidity for patients, as you can imagine. So this was an accreta case that I did in Rwanda. We had suspicion for it based on ultrasound findings, and so we were prepared. And we can talk about the clinical preparations for that separately if you guys are interested. But we deliberately tried not to deliver the placenta because we could tell from the imaging that it was most likely an accreta. The uterus started to contract after delivery of the baby. And so it's sort of, instead of being able to close up the uterus and just do the hysterectomy like we normally would, the uterus contracted down really tightly, mainly because the oxytocin started running from the anesthesiology side. And so it pushed the placenta like out of the uterus, and we like couldn't shove it back in. And that all happened in like the first 30 seconds after the delivery. And it was really annoying, but it led to this like really good picture where you can actually see the connection between the uterus and the placenta in the way that it's like fully invaded and not able to get delivered. The table here is from Dr. Silver, the chair of the OBGYN department here, who's done a ton of research and work on placenta accreta spectrum disorder. And this shows the relative rates of surgical complications like holes in the bladder, damage to the ureter, pulmonary embolism, ICU care, surgeries, and postoperative infections. And you can see that these are all like less than 1% in most C-section deliveries that aren't complicated by an accreta. And then with very significant p-values, you've got really high increases up to 15, 26% in terms of bad things that happen to patients who have this disease. This is another really challenging case that I took care of postoperative infection. There are a range of different infections that can happen at the surgical site, inside the uterus, at the level of the fascia, at the level of the sub-Q or the skin. And this patient had probably a postoperative superficial surgical site infection that was left unaddressed for about 6 days while she was still in a healthcare facility. And she got the wrong kind of bacteria and it was fasciitis. So all the green tissue you see on her, all debrided, was recurrently dead tissue that was just being eaten away by this terrible infection. The general surgeons there actually thought that her infection was too far gone to even try taking her to the operating room to save it, but it felt really bad to just leave her on IV antibiotics in septic shock in the ICU and not do anything and just like watch her rot to death. So after talking to her partner and some other family members, she was obviously unconscious. We decided to try. And we did a few debridements and ended up being pretty successful in healing her wound. Her overall story is not a happy one, unfortunately, but the wound healing did actually go really well, as you can see in the second picture, where she was able to get clean surgical margins at the level of debridement and a lot of good granulation tissue and healing. And she would have needed some plastic surgeons to come and help us with reconstruction eventually if she had been able to make it. This is a stat that goes along with her case, where now in Rwanda and in a lot of other countries, postpartum hemorrhage, which used to kill most women in childbirth, is actually not the leading cause of death, maternal mortality. It's sepsis and infection after deliveries, usually after C-sections. And in Rwanda specifically, there was a study done, published in the leading OBGYN journal here in the United States, like a really high quality study that showed that 50% of maternal deaths in Rwanda are from sepsis after C-section, dating from 2017 to 2019. And that trend has continued every year since.
Last question. Is there like some suspicion that it's sort of a trade-off, like the reason why postpartum hemorrhage gone down is because C-sections have gone up, but that sort of trade?
Yeah,
I don't know enough about.
That's a great question. I think, yeah, teasing that out, I think from like an epidemiologic standpoint is multifactorial. I think the C-section rate is rising, which would definitely increase that. I think also that for Rwanda specifically, there's a private company that started working there about 5 to 7 years ago that sends drones, sets up drones. It sends drones all over the country from the central facility to smaller healthcare clinics and delivers blood. And it's this really cool company. It's like a tech startup out of San Francisco. And they're in about 6 countries in sub-Saharan Africa. And they're about this big, maybe like remote control styrofoam planes. And they get like slung out of a slingshot launcher. And then all managed by computer systems. They like fly to the healthcare facility with the blood that's like been scanned and ordered for the patient based on all this like exchange of digital health information. And it can get anywhere in Rwanda in like less than an hour and sometimes way faster. And it has, I think, saved a ton of lives from postpartum hemorrhage. I don't know that we're always managing hemorrhage super well, but we are resuscitating patients better in that context, which I think also led to this change.
The cause of the sepsis, do you think it's occurs at the time of the C-section, like intra-abdominal? Or do you think
Question.
Post-op?
I think it's mostly
skin infection.
It's mostly
that works.
I think it's mostly post-op. And I think one of the main causes is poor perioperative prophylaxis. So inconsistent use of IV antibiotics at the time of the surgery, pre-existing infections if it's a C-section that was done during labor. Surgical technique, I think, is a big part of it. Environmental factors related to just like the sterility of the OR and these old buildings and lack of power and all, all the things that you're very well familiar with in a global health context, I think all lead to higher rates of infections either in the uterus, in the fascia, or the skin and soft tissue.
Do you think that any of it has to do with poor antibiotic stewardship? Because a lot of antibiotics are available at pharmacies without any prescription.
I do. I think that's also a great question. There are, and I think it's probably both related to stewardship and also maybe some bad bacteria, which also are promoted by antibiotic stewardship. The resistance patterns in some bacteria that we've seen in these patients and in the ICU are crazy. Like multi-drug resistant Acinetobacter that has absolutely no sensitive agent except what, really awesome extended spectrum beta-lactamase resistant gram negatives. There's some really bad pathogens, and there's been some antibiotic studies or susceptibility studies, including sort of proven this, but again, there needs to be so much more research done on that topic and on how we can better tailor process, which we extrapolate from our Western literature, like, oh, let's give cefazolin to everybody, Azlet to everybody. But like, is that the best? First of all, it's not usually available in Rwanda. Usually we use ceftriaxone. And is that, it's based on a guideline that we use in Western countries. Does that really make sense for East Africa? Maybe, maybe not. We don't really know.
I have a question related to that. So my context is Nepal and India, and it is not a requirement of CEONCs or hospitals that can provide C-section capabilities to even have the ability to do a blood culture. So we often find ourselves in the same boat on the neonatal septic side, where it's like the baby looks like it looks, and so we do the antibiotics that we have, and we often don't have any idea what we're treating. And then the literature that comes for us on our side are often study based, where it's funded to sort of look at the microbiology and the antibiotic resistance, but they're often old and they're few and far between, and they're funded studies, and then we actually don't have any capacity to do continued epidemiologic studies. So I'm curious, in the Rwanda context, do you have blood culture? It sounds like you do. I'm hearing you can even do like susceptibilities, but is this part of the regular practice, or is this something that's like out of the ordinary, outside of the normal workflow that you're doing there?
So at this hospital, because it is like the flagship public hospital in the capital, blood cultures are available. Blood cultures and wound cultures are available. For newborns, it's a little bit less consistent, and there are some cultural factors that I think inhibit. And then also a lot of times there aren't enough tubes. So like they're possible, but sometimes there aren't the resources to do them. And then if you go to, caveat to that is that most deliveries don't actually happen at this facility.
That's right.
And they happen at smaller facilities with usually general practitioners actually who haven't even done a residency in obstetrics and gynecology, who haven't been trained in surgery except in so far as they assisted during their medical school rotations. And then they're sort of proctored-ish by other general practitioners once they start their professional internship. And so there's a lot of unsafe C-sections that are being done. And we see a lot of the complications that are done elsewhere, and then they come to this facility. Just one more, oopsie, here we go. This one was an interesting patient who, when she was transferred from the other facility, she had like a big bandage on her abdomen, and it was covered in gauze and tape, and we figured it was a closed surgical wound, and because she was awake and not anesthetized. And then we took the bandage off, and this is what it looked like. Her incision wasn't closed, and there were all these clamps like in her abdomen, different blood vessels and things that were trying to stop hemorrhage, and her uterus was still inside. The reason this patient lived is because you can also see here, there's like the tip of a Foley catheter. So this is a pretty common practice in low resource settings to mitigate postpartum hemorrhage at the time of a C-section, or you can do a laparotomy with taking it's called like using a tourniquet. So you basically take a Foley catheter, wrap it around the lower portion of the uterus. You ideally want to get the uterine arteries, but you can also, if you want to be really blunt about it, you can also get the ovarian vessels, and you just tie it as tight as you possibly can and cinch off the blood flow to the uterus, and then send the patient wherever she needs to go in order to get the hysterectomy that she needs. If you can't perform the hysterectomy at your facility because you don't know how or you don't have the resources. And so this lady had 3 tourniquets cinched tighter than I've ever seen, not only around her uterine vessels, but also around her ovarian vessels. And it's the only reason that she didn't bleed to death on the way to our facility, because I think she gave 4 hours in an ambulance. So we were able to take all of that off, resuscitate her with blood products, and then do the removal of the uterus, which as you can see is kind of like exploded open. That doesn't usually happen spontaneously. It's more common to occur after a C-section. So the more C-section somebody has, the higher likelihood there is that the scars on the uterus don't heal right and are kind of thin, not as strong scar tissue that either separate just from the growth of the uterus in the 3rd trimester or from the modulation of the tissue and the contractions that happen during labor. So if we're doing a trial of labor for a patient who's had 1 C-section before, we do that all the time here in the United States. We just do it with really close monitoring. And in the back of our mind, we're always making sure that we're not missing a diagnosis of spontaneous uterine rupture. And that's a conversation that we have with patients before they decide that they want to try to have a vaginal birth as opposed to a scheduled C-section. Oh, and so when I downloaded this from Google Slides to PowerPoint, some wonky formatting happened. But essentially, I just want to highlight the fact that in addition to the too few and too many C-section concept, when you then think about this in the context of developing countries aren't monolithic, and there are rich people and there are poor people and there are people with access and people without access. And so as this upward trajectory of cesarean deliveries occurs, we're going to continue to have unmet need, especially in poorer rural subgroups, and we're going to have overutilization in richer urban subgroups. And there's data to suggest that that's already happening. And most likely, if we know anything about inequity in healthcare and in women's health in the United States, that's going to happen in these other places as well. So this is the last part of the talk, and then we can do some discussion. I'm just going to show you a little bit of the data that I have from the University Teaching Hospital of Kigali. That's where I was working. We did a retrospective review of the C-section logbooks. So there's these like big blue books that have like a bunch of columns for data entry, and they're all written in by hand, and the papers are like old and crinkly. It's like kind of hard to figure out what it says, but that's like what the data is. And so we went through 2 years of consecutive cases from June 2022 to May 2024, and just put into a spreadsheet what was already there in the book. Super tedious. What were the indications for the C-section, the basic obstetric data, and maternal and neonatal outcomes? The maternal and neonatal outcomes are like not well captured in this book at all. But why the C-section was done is pretty reliable. The fact that the C-section was done and the obstetric data was pretty reliable. We had 2,530 C-sections in the data set, which is a little bit more than 100 per month done at that facility. We manage the postoperative complications of way more C-sections than that, but those are patients who are operated on elsewhere and then transferred in. There are obvious limitations, the logbook that I described, the retrospective nature of the study, and many other things, but it gave us a little bit of a snapshot. The data is not super well processed, so these are screenshots from my STATA program. Here is a table of the scheduled versus unscheduled cases based on the number of prior C-sections. The number of prior C-sections are here on the left. You guys can see the pointer? No, yeah. Because I think the laser doesn't really show. So no prior C-sections, 1, 2, 3, up to greater than or equal to 5, and then scheduled, yes or no. The scheduled part is important because it's a proxy for whether the patient had planning for the C-section, which is important, especially if they've had a history of multiple prior ones. Like if they're getting good prenatal care, they shouldn't just like all of a sudden go into labor at 40 weeks with 3 prior C-sections. Like that should have been planned for sooner. And then for scheduled cases, I'm sorry, for patients who labor and then end up going from labor to a C-section, that's always going to be unscheduled. So this breakdown helps us understand which schedules were which C-sections were done while attempting a vaginal birth and which ones were done without trying that. And what we see, if you look at the first column, the first row, 14% of patients with no prior C-section, meaning no surgical history to suggest that they need a C-section, were done in a scheduled manner. And that translates into actually like C-section by maternal request, which is really common at this facility in Rwanda, and in my perspective, a very big problem. What else is in here? The other interesting part about this is that you see that yes column, the percentages here, which are the second number, like the 14.08, the 54, the 64, the percentage of cases that are scheduled rises up until about 2 prior C-sections, and then it starts to fall again. So you've got these higher order C-sections of people with 3, 4, or 5 C-sections who absolutely should not be having a vaginal trial of labor. More than half of them are not getting scheduled and they're just like showing up. And that's also a big burden on the healthcare system. Like, surprise, I'm in labor, I have 4 C-section scars, you're just meeting me. Not great. And again, this is not a critique of the hospital or the care. This is just the system that exists as it currently is. And the whole point of getting data is to understand where are the parts of the system that may be modified. Here we can see the C-sections by indication based on the logbook. You can see that maternal request, prior scars, and preeclampsia are really the only indications. It's actually pretty shocking that there aren't any other indications in there except the scars and moms that are asking for them. And if you look at the cumulative percentage here, right here, 35% of C-sections are done because the mom asks for it. And then just almost 70% of C-sections are done either because mom asks for it or because they have 1 prior scar. And that is really interesting because 1 prior scar, in theory, with a robust enough healthcare system, could, in most cases, have a vaginal trial of labor. We call that TAL, and it leads to, or TOLAC, trial of labor after C-section. So you might have friends, family members, mothers here who had a vaginal birth, had a C-section, and then for their next or 3rd delivery decided, let me try that vaginal birth 1 more time, and it was fine. You can do that, and you can reduce the C-section rate by increasing the number of people who undergo that procedure, but we don't really have that capability to do it well at this hospital. But if we were able to catch that, and if we were able to understand the values behind the maternal request for C-section a little bit better, and the factors contributing to it, that's 70% of the C-sections. Like, that's crazy. So here, you could make the case that, okay, this doesn't have a lot of other information, right? All I know is like the number of prior scars. There could be a million other reasons. There could be a breech baby. There could be severe preeclampsia. There could be a really crazy infection. There could be preterm labor. There could be lots of reasons why we want to do the C-section. So if you restrict the data to just term pregnancies, which are 37 to 41 weeks, as you can see in the columns at the top, you essentially get the same data. So if you have 752 out of these 2,140 C-sections that are done in term, that's 35% of the C-sections. And then if you include the maternal request and the one-time scar, that's 69% of the term C-sections. So the trend is exactly the same, even when we exclude preterm births. This last one here is taking the same data, but looking at it by gestational age instead of by indication. And this sort of shows us a couple things. It reflects that maternal request is a proxy for the first C-section in a lot of patients, including a lot of patients when they would be normally like induced for a vaginal delivery here at 39 weeks. 25% of the deliveries that were done in the 39th week were, 25% of the C-sections that were done in the 39th week for patients here were done by maternal request. And as we saw in the prior table, most of those people on maternal request didn't have a prior scar. 80% of these C-sections are happening at 39 to 41 weeks. And they represent a quarter of all the C-sections that are done. And that's important because there's this concept here in the US that became apparent, really pushed by the California Maternal Quality Care Collaborative, which does a really amazing job improving birth outcomes and decreasing C-section rates. There's this concept called MTSV, and that means nulliparous term singleton vertex. And it means that it's one baby in the uterus at term with the head facing down, which means like in a first-time pregnancy. So like a perfect setup for a vaginal birth. So if you follow that rate, it's a little more targeted as to the people who really could be avoiding a C-section, but aren't. And if you follow that number specifically, you can do like a good job of knowing how well a place is doing. And so this data shows us that we've got a lot of nulliparous term singleton vertex people getting C-sections. And based on the photos that I showed you and the stories that I told you, it would make sense that maybe we try to get some of those to switch over to vaginal deliveries. So the whole takeaway from this is that there are a lot of intervention targets and projects that can be done here at CHUK in Rwanda, and I'm sure in many other contexts where these patterns are occurring. You could target the nulliparous term singleton vertex group. You could target the group of patients who ask for C-section and understand why that happens. A lot of those happen during labor. And I think, it's a separate topic, but intrapartum, so the ones that happen during labor, you could target those with labor management interventions and education. There are some C-sections that happen during the second stage, which is like when you're actually pushing the baby out. And there are alternatives to like operative vaginal delivery with vacuum and forceps that are sometimes the path of least resistance relative to a C-section when the baby's like almost already out of the vagina. That's an intervention that could happen. Increasing the number of women who are allowed to try for a vaginal delivery after one prior C-section is another area. And of course, working to increase the safety of C-sections, regardless of where they're performed, and mitigate postoperative complications is another area. And I think there's a lot of like sociocultural, maternal, and provider attitudes that are different from the way we think about route of delivery here that warrant exploration to understand. And this is just like a snapshot of some of the stuff that I, over the years, want to try to work on. That's all. Yes.
That was amazing, Patrick. That's amazing. So I know, I'm a neonatologist, so I deal with the aftermath of all of the things on the baby side. I'm going to do this with you in Nepal. But I actually think on the bottom of your list, the attitudes and sort of provider, both maternal, I think that's going to be a huge deal. And I don't know the context of Rwanda. We had the last conference where the urology folks presented on fistula and things like that. I'm sure there's a lot to unpack with like fear of vaginal deliveries and what's going on. So I think that's a whole project, multi-layered project in and of itself. I wanted to ask two things. One was related to the stigma and sort of exploring the maternal attitudes specifically, like just requesting one. I know some of the anecdotal things in Gujarat and also in Nepal is that C-sections are a amenity of the more wealthy, and so it carries its own
status symbol.
But my daughter can have a C-section, and so there's a little bit of a stigma like a positive stigma surrounding the opportunity to have a C-section because you're in a facility with an obstetrical provider, etc. The question I wanted to ask for you is, do you think that there's a possibility for secondary gain in the provider side or hospital side, like what the insurance setup is, if they pay for C-sections and how that works? Also, context for Nepal and India, there's no government like healthcare insurance schemes for babies. For women, there are some, but then there's expectation they get paid out of pocket. So I'm curious about your thoughts on conflict of interest in providing a procedure that would then benefit the hospital or the providers financially.
I think less so and in the public health facilities, but there are a lot of private practices, especially in Kigali. I think that's a huge problem. And I think it's because it's more convenient for the providers and more lucrative. They are able to bill more for surgical deliveries, just like here. You get paid more for a C-section. Well, actually, care here is bundled often. If you get consistent prenatal care, so you just get it all billed globally in a like too low rate. But I think there's a convenience factor a lot. Like people don't want to be on the labor floor. Sort of the messiness that is labor. You just like do a scheduled case and then have it be over with. I think that's a huge thing. I think the social class part of it factors in a lot. And then something that's interesting for that I saw in the hospital, it was logistical. It was like the labor room was like 6 beds separated by thin sheets that were really not private. And we had patients who would come in for induction of labor, say they were approaching 41 weeks for their first pregnancy. It's not uncommon for labor to have not started and to need an induction. And that induction process in the beginning can take a really long time, even up to like 24 hours to get the cervix sort of ready for labor. And so you've got a woman in bed number 1 who is going through that process. And then in bed number 2, 3 different women with their second or third baby have come and gone while she's just like waiting for her cervix to get right before her contractions even start. And so there's a huge like disconnect and misunderstanding in terms of the patient's perception of the care they're getting and the communication between the providers and the experience of the other patients nearby, and make them be like, this sucks, I quit, I want to have my baby, please just let me have a C-section, this is terrible. And I had a ton of patients who wanted that. And it like broke my heart, but I had to just get over it because I wasn't going to be able to fix it right then and there.
Any other questions? And then I'll stop asking. 2-part-ish. So you said that the indication, and I know this is all retrospective, was like scarring. And I'm wondering, one, what if any fetal monitoring there is. And then I might have missed it in the slides. But if there was an improvement or a change in newborn outcomes, like with increase in C-section rate, are newborns doing better? Like, is there another like secondary driver to say our newborn mortality is going down? So
I didn't finish analyzing the newborn stuff yet. And I also didn't finish doing there was like a secondary indication for cesarean delivery. That is the primary indication was literally only 6 that you saw for almost 2,500 births. The secondary one was really varied and not systematic. So I haven't actually finished going through and like cleaning it and coding it and deciding how to like organize each of them. Same thing for the neonatal outcomes. But on first pass, there's not like an appreciable improvement in how the babies do with C-section versus vaginal. It's much more like provider, patient, like just entrenched practice pattern driven. Yeah.
I'm trying to think of how to structure my question so it's not confusing. So it sounds like, the main variables that you hypothesize are sort of driving the high C-section rate is the patients wanting it and the doctors maybe not knowing better than to not offer it. So sort of allowing that maternal request to be okayed and like move forward with it. And so I guess my question is I think the patient intervention side of it is probably pretty hard to achieve, to change like all the cultural kind of things associated with why somebody might want a C-section. But the provider side of agreeing to do an unindicated C-section probably is a more reputable place to work. And I guess my one question is, how do you think you can target that, the providers? And my other question, especially in light of like, C-sections being like a hot thing to be able to do, and in light of, concern sometimes that if you don't have surgical cases, you can't teach surgical cases. So I imagine there's some element of wanting to do C-sections so that people have and maintain their skills. But I guess in that context, my question of like, how do you target the providers is just a little bit of an interesting anecdote from the urology side of things, which is that the Ministry of Health in Rwanda is super interested in sort of building up their vesicovaginal fistula repair, female urology, female incontinence practice. And vaginal delivery gets blamed for all of those things. And it's just interesting because I recently talked with a female urologist who's been sort of summoned by the Ministry of Health in Rwanda to do this work. And her uninformed perspective was, oh, they need to do more C-sections in order to reduce the rate of things like, obstetric related vesicovaginal fistula, or, severe
Prolapse and urinary
incontinence,
later.
prolapse, and all these other things. So it feels like a conflict of interest. So I guess my question is really just about training the providers, but also in the context of sort of that competing issue.
Yeah, and I think you hit the nail on the head with like the interconnected pieces that have to be put on the table in order to then ask like the underpinning question to get to the root causes. So thank you, because it's really hard. I agree with you that training providers would be easier than changing patient norms and perspectives, and that once the providers change the way they approach the topic with patients, it could slowly over time start to change patient and community level values. One way that I would love to tackle this is by starting like a group, like an interest group. And I wrote a grant that wasn't successful to like this random British funding agency, but I was like working on it with a resident because she was interested in it, and we're gonna like leverage it for some other things. We could also probably do it for free, but the idea is to create this Rwanda vaginal birth collaborative and get stakeholders from obstetrics, from pediatrics, from anesthesia, from hospital administration and the ministry, and from the community to just start to meet on a regular basis and talk about sort of the relative pluses and minuses of vaginal birth, start putting C-section complications, which everyone in Rwanda knows. That people know that the C-section infection rate is really bad, at least in the healthcare system, and that postpartum hemorrhage is still a problem, and like all these things. And postpartum hemorrhage is more common after C-section than after vaginal birth. So yeah, I thought like a kind of grassroots organization of getting stakeholders to start to talk about it, and then start to look at their own individual facilities and small things that they might be able to start changing would be a really good way. And then have that group of people also help lead small initiatives like starting like a provider training or something. There's a hunger for continuing medical education and for like research advancement, as you know, among so some of that interest to introduce other ideas that, maybe we could target who gets C-sections a little bit better than we do right now. And we could save people's lives and save the healthcare system money. So open to many other ideas. Yes, Dr. Price.
I always we surveyed the people of Mongolia. Where they get information. It's not so easy. Family. That's it. So serious.
I would love to talk with you and see what you guys design the survey. So, since I'm super delivery, so I'm really interested in how they think about it to their pregnancy. I don't think it's a single snapshot in time that people know and feel that they want this thing versus that thing. I think it's probably one way, and then in prenatal care at different periods, it's probably another way, and then intrapartum, it's probably another way, and then postpartum, after they have one or the other, who knows what that sort of reflection looks or feels like. And so I would love to, I'm very interested in studying that, and I think understanding what the drivers are.
From population things, breast cancer in Ghana, been working or trying to get to many groups. We're going to churches and to hitting the adult population. And Breast Cancer Society finally said, we're just not making any progress. What if we attack the next generation? And so now they've developed a whole course that they have the healthcare people in the high schools work with the students to put on a fun play that addresses the misperceptions about breast cancer, and then a PowerPoint, and then a whole bunch of stuff. We're in the process of looking at 6 months after going into multiple of these high schools, set 2 trainings, and what's kept and what's not. But is there a way to address those kinds of things on a different way that we haven't thought about?
Yeah. That's great. You saying that actually reminds me that I think a similar program for breast cancer specifically also exists in the Rwandan schools. I think pregnancy related things might be harder to rally around in school.
Well, yeah, I'm not
But
saying do schools, I'm just saying it's a different,
venues, yeah.
in terms of addressing a public as opposed to doctors. I think doctors are great. We have a lot to do there. I guess my question is just the doctors alone the greatest impact that we would have?
Insufficient is better.
I agree with you. So doctors, from at least the work that I do, with the neonatology in Nepal and India, the doctors are actually the least helpful target. Yep. For all kinds of reasons. We get sort of stuck in our ways, etc. But we've actually made the most impact in an adjacent project for cervical cancer screening that Kate Harris was involved in also, at the level of the community with community health workers and being able to address women specifically separate from men because of the stigma related to that, but looking at feasibility and acceptability of self-swabbing for things like cervical cancer. And that's best handled, at least from our experience, in the hands of the community health workers who really know the women, know the culture, and are out doing it. And the hospital, the connection between the community and the healthcare system, that's sort of the gap that we found and how to bridge that gap. Because once they're in the hospital, they're in, and that's great, but actually getting them to interface with the hospital is a different beast.
I wanted to touch on that first one because obviously going into another country, some doctors will kind of look at you like you're basically just coming here to teach me because I don't know, and they kind of take offense to that. So is that one of like the reasons that maybe you don't want to target doctors and we're going straight to the community, or was it just like because you've been there before? So is that one of the reasons, or what are the reasons that you wouldn't or didn't want to target them first before the community?
I think we would, I was there really for us to kind of establish our relationship and build our partnership and be as useful as I could, knowing that I wasn't from that context. So I did all of the clinical work that I did through the residents. So the hospital that we were at was a really good place to send like a foreign fellow, an American fellow, because I wasn't sitting there trying to do my own consultations in Kenya, Rwanda with no sort of cultural knowledge of where the patients were coming from. I was like supporting the residents who were either doing these surgeries or trying to suss out clinical encounters and bedside conversations with patients. And I was doing that alongside a bunch of really amazing Rwandan doctors. And so I think the appetite for self-reflecting, like, and that's why I collected the data from the actual hospital, like looking at results and realities from my Rwandan colleagues' own practice is a good place to start, because they're very open to being like, oh, what are we doing? And could we do it better? Because there's a really strong appetite that comes through in every morning meeting, every sign out about how do we continue to improve and continue to provide better and better care for our patients. Like that, everybody's united in that goal. And a lot of times the system itself is just set up in a way that there aren't enough incentives for any one actor to like tip the balance of the way things are happening. And so I think there's a way to go about talking to colleagues from other contexts about behavior change or changes in practice. And you can do it in a way that's sensitive, or you can do it in a way that's really gonna mess you up and cause some rifts and offend people. And that for sure is something that we have to be really mindful of, like keeping that cultural humility all the way throughout and making sure that it's not something that we want and are imposing, but something that we are bringing up as a topic, maybe showing is rooted in real evidence from that specific facility, and then talking about if anybody else wants to change it.
I think that's going to be my next question. How do you target other centers in Rwanda?
Yeah. I think some sort of like Rwanda Vaginal Birth Collaborative would be great. And what's nice too is that the Ministry of Health is pretty organized in Rwanda, and there's RSOG, the Rwanda Society for Obstetricians and Gynecologists, which is like the Rwandan correlate to what we have here, which is ACOG. And so it's like a professional society of they don't have board certification, but most of the practicing OBGYNs, and everybody knows each other. there's like WhatsApp groups and like, so if you get into those informal networks and you have the relationships, you can sort of penetrate more broadly than just the hospital that we were working at, because everybody knows somebody who's working somewhere else. Yeah, there's only there are less than 150 OB-GYNs in the whole country. So it's a totally like surmountable group of people to reach at this point.
I'm not sure if
Thank
it's
you guys for
useful. Hello?
thought-provoking questions.
Hello?
I'm gonna peek at the chat.
Somebody's asking something, I think.
Yeah, I think
Mhm.
most of I wanted to ask a question. Mo, I can hear you. Can you guys hear him in the room?
Hello?
Yes, we hear you.
Yeah.
Okay.
Go ahead, Mo.
I'm not sure if it's a useful question, but I would like to know if you look at two healthcare system with the, let's say, very good resources. One of them is low frequency cesarean procedures, and the other one is high frequency cesarean procedures. Which one fared better as far as the outcome for the mom and the newborn?
My instinct would be that the low frequency centers would fare worse.
Would fare worse.
Yeah.
Okay.
But I haven't looked at that in the Rwandan context specifically, but generally with and I'm sorry, I don't know you or your background, so I hope I'm not saying things that are that you know already or that are not interesting. But in general with surgical safety, higher volume and frequency of specific procedures usually have better and safer outcomes. And when individual providers or specific centers do a type of procedure less often, then there's higher rates of complications. So it's kind of counterintuitive because but C-section is pretty routine surgery until it's not. And it's the OB-GYNs there who are doing it are definitely not at risk for atrophy of the skills for C-section. For something like hysterectomy that's rarer, that definitely is a concern. But C-section, both here and I think in most other contexts, like people are, they're being done at such a frequency that the fear of losing the skill is not the biggest priority. I don't know if I totally understood your question, but I hope so.
Yeah.
We should probably wrap up because it's after the hour and I think Patrick has to get back to clinic.
Thanks, everybody.
So thank you so much, Patrick, for a fantastic talk and great discussion. Just to let everybody else know, we won't have a talk next week because it's our American College of Surgeons conference, and either people are at conference or on call. So that's next week. But the following week, I want you to be aware that we'll have our second Global Health Research Grand Rounds, and the speakers will be Dr. Melissa Watt and Dr. Stephen Kimani from Population Health Sciences and Dr. Geeta Suneja from the Department of Radiation Oncology. They will be talking specifically about cancer research and stigma. So for those of you asking about stigma today, that'll be a really great talk to come to in 2 weeks, and we will also have lunch. So thanks so much.